Okay, so let's continue. We did the anatomy, so let's start with urine formation. So now we go on to the physiology of the urinary system. So how is urine formed? Okay. So again, the process of urine formation, the goal is that you need to maintain homeostasis. So the amount of water in the body should be maintained at a constant level. Electrolytes should be maintained at a constant level, and waste products have to be thrown out. Okay. So there are 3 steps to the formation of urine. First is filtration. Second is tubular reabsorption, and the third is tubular secretion. All these 3 processes ultimately lead to the formation of urine. So let's see what these are, one at a time. Glomerular filtration. So this is a diagram to show you the 3 processes. Filtration is when the substances are filtered out of blood. So where does this happen? This happens in the first part of the nephron, which is the renal corpuscle. So glomerular filtration happens in the so this is the first step, filtration, and this takes place in the renal corpuscle, which is the glomerulus plus the cup, the glomerular capsule. That's the first step. Okay, and we have already seen what happens. So the filtrate has everything in the blood, everything similar to blood. Okay, it will have waste products, waste, it will have nutrients, water, electrolytes. But the only thing that is not there in the filtrate, what is not there in the filtrate is the plasma proteins and blood cells. Plasma proteins and blood cells don't get filtered out. Okay, so you can see that the filtrate, there is no check here. There's no check here. So you don't have a mechanism by which you only remove the waste products, filter out the waste products. That doesn't happen. So everything gets filtered out. Whatever is small, tiny, lipid soluble, everything gets filtered out. So it is the job of the tube, the renal tubule, to actually take back what is already necessary for the body and leave behind the waste products that have to come out in urine. So that is what happens in step 2 and step 3. Step 2 and 3, these two happen in the renal tubule. So when I say renal tubule, that would be the proximal convoluted tubule, the nephron loop, and the distal convoluted tubule. So 2 is tubular reabsorption. It's not absorption, it is reabsorption. So what is tubular reabsorption? The definition of tubular reabsorption: transport of a substance from the filtrate in the renal tubule back into the blood flowing through the peritubular capillaries, that is the capillaries that are next to the renal tubule. So the body is taking back whatever it requires. Okay, so I'm going to give you the definition of tubular reabsorption. And somehow I've always seen every semester that tubular reabsorption and secretion, students get confused with this. And I mean, it beats me why. I'm not able to understand why, but somehow in the exam, whenever I ask a question, it becomes different. Tubular reabsorption, transport of a substance from the filtrate flowing through the renal tubule back into, so it is transport from and into the blood flowing through the peritubular capillaries. So this is kind of like a detailed explanation. So essentially it'll help if you remember this diagram and you remember this arrow. So a substance from here getting into the blood. Okay? So tubular secretion, tubular reabsorption, if you look at it, it is for, and this is an important thing, if you remember this, then you will see. You will be able to not forget what it means. For useful substances. Okay, so would you want to throw out useful substances? Your body needs to conserve useful substances. Okay. So it is something like, suppose your family is thinking of having a yard sale or something. And if you have a few members in your family, you tell them, okay, whatever you don't want, please come and put it here in the basement. Okay, and then as the mother or the father, you will say, okay, I will then decide which one needs to go, which one we need to keep back. So that collecting all the items for a yard sale, that is like filtration. And then the person, the head of the family, deciding which one needs to be kept back because it is useful, we may need it later, that is tubular reabsorption. Okay, and whatever is not needed, you put it on a sale because you're no longer using it. So something to that effect. So tubular reabsorption is for substances that are needed by the body. So the body has to take it back. So that's what happens as the filtrate flows through the tube. Now tubular secretion is the opposite of tubular reabsorption. The exact opposite. So all you need to do here, if you look at the definition, transport of a substance from the blood flowing through the peritubular capillaries into the filtrate flowing through the renal tubule. So you just have to interchange it. So look at the arrow. And I'll tell you why. You might wonder, why is this needed? Transport of a substance from the blood flowing through the peritubular capillaries into the filtrate, from the blood into the filtrate flowing through. So it's all in motion. This fluid is moving, blood is moving. So nothing is stationary. But as it is moving, this happens. Flowing through the renal tubule. So the exact opposite. Now again, remember, tubular secretion is for unwanted substances. Whatever needs to be thrown out in urine. Because once it comes into this tubule, it will be thrown out in urine. So this is for useful substances, tubular reabsorption. Tubular secretion is for unwanted substances or waste. Okay? Now comes the question. You said everything is getting filtered here. Okay, filtration has already occurred. Waste products have come out. Nutrients have come out. Nutrients get reabsorbed. So what is this process necessary for? Why If everything has been filtered here, why do you still need this extra mechanism? Now that is, so this tubular secretion is needed for substances that escape filtration. So some of them are, very smart. As the blood is flowing here, filtration is occurring, but they may escape filtration and get into the peritubular capillaries. So for substances, especially waste, for waste substances that escape filtration. That is one reason. An example of this would be creatinine. So, almost about 80% of creatinine will get filtered. 80 to 90 gets filtered. But about 10% of the creatinine will sort of escape filtration. As blood is flowing, some of those molecules will escape. So this is an added mechanism to push them out, to throw them out. Okay? So example would be creatinine. And another example, acids. Okay, hydrogen ions. Also are thrown out like that. Second reason for tubular secretion. Why do we need this? The second reason is, if the molecule that needs to be thrown out of your body is too big, if the size of the molecule is too big, it cannot come out through those tiny openings in the podocytes, it cannot filter out. So you need a mechanism to push them out. Okay, you need to throw it out. They can't stay in the blood. So tubular secretion is also for molecules that are too large to be filtered at the glomerulus. They cannot be filtered out. Okay? And a prime example of this would be, is the breakdown product of drugs, the medicines that you take, drug metabolites. Drug metabolites. So every time you take an aspirin or a Tylenol for your headache or pain, the drug produces its effect, and then the liver breaks it down into non-toxic products. It breaks it down. And then the product has to be thrown out in urine. Okay? That's why whenever your physician prescribes you antibiotics, they always tell you, drink plenty of fluids. Okay? One reason is if you have a fever, you get dehydrated. You have to have water. But the other main thing for asking you to take fluids is to allow for these drugs to be washed out in urine after they have produced their effect, whether it's an antibiotic or any other medicine that you take, has to be, the breakdown products of the drugs have to be thrown out in urine. And they don't get filtered out because they are slightly larger molecules. So this is another mechanism to do that. Okay? And tubular secretion is always an active transport process. You need to use energy to push the substance out. So ATP has to be used to push this out. Yes. So that is tubular reabsorption and secretion. Okay. So glomerular filtration, first step, tubular reabsorption. Go back today itself and just go through the definition. So that way you will not make a mistake. It's not difficult to understand. If you just put your mind to it, it's not difficult. So this is for useful substances, taking it back. This is to throw out the extra substances. Okay. Now, you know where glomerular filtration takes place, renal corpuscle. tubular reabsorption, the part of the tube, it can occur throughout the tube. The proximal, the loop, the distal, the collecting duct, it can occur everywhere. But maximum tubular reabsorption, and we are going to look at this, maximum tubular reabsorption occurs in the PCT. Don't forget this is important. PCT, proximal convoluted tubule. That's where maximum reabsorption takes place. Almost everything is getting reabsorbed there. Very little when it comes to the loop and the DCT and the collecting duct. Okay? So most of the reabsorption happens as soon as the filtrate enters the proximal convoluted tubule. A lot of things, all the useful substances get reabsorbed. Now, tubular secretion can happen throughout the tube, anywhere. PCT, DCT, loop, okay, collecting duct. So it can happen throughout, depending on the substance. Now, urinary system is a very complex physiology here. So we are just going to touch the surface. You're not even going to look, because if you take every single substance, the transport mechanism is different, where it gets reabsorbed is different. So lots of intricate details are there, which we are not going to go into. But at least so much you have to remember. Okay? So now let's start with glomerular filtration, which is the first step. Okay? Now glomerular filtration, again, I've already mentioned to you that it happens in the first part. Okay? And we've seen all this, we'll do this. So the glomerular filtration is actually a very simplified process, because the membrane through which the substances have to filter out is very, very thin. So you have the podocytes, which is the visceral layer of the glomerular capsule, and then you have the endothelium. Both the endothelium, that is the capillary endothelium, and the podocytes have lots of openings, lots of tiny openings. So substances can filter out very easily. Okay? So before we look at how the substances get pushed out, very similar to what we learned in capillary exchange. Okay, it's very similar to that. But before we look at that, how much of filtrate is actually formed by all the nephrons? So on a daily basis, how much of filtrate is formed? So we're looking at glomerular filtration. So there are about 2 million nephrons, right? So roughly on an average, it is 180 liters in 24 hours in a day. 120 liters a day. Okay. What is your blood volume? 5 to 6 liters. Out of that 5 to 6 liters, only 3 liters is plasma. But see how much of filtration is occurring. 180 liters per day, which amounts to, if you calculate it per minute, 125 ml per minute. This is known as the glomerular filtration rate. Glomerular filtration rate, or GFR. An important index of kidney function. This is an important index of kidney function. What is the glomerular filtration rate? How do you define it? The volume of filtrate formed by all the nephrons in both the kidneys. So this is the total. Okay? So you have 2 million nephrons. If you look at how much filtrate is formed by all the 2 million nephrons in both your kidneys, it is 125 ml per minute, which amounts to 180 liters per day. But this is the value that we usually measure. So you have to remember this, 125 ml per minute. Okay, GFR. Now what is this filtrate? Protein free. There is no plasma protein in the filtrate. It is very similar to blood plasma. Has all the electrolytes, water, sodium, potassium, calcium, magnesium, along with all the waste products and the organic substances like glucose, amino acids, fatty acids, vitamins, okay? All of those will be filtered out. So useful substances plus the waste products. Okay? What is not found in the filtrate should not be found in a normal filtrate is plasma proteins and blood. Okay? This should not be there. Now, having looked at the GFR, the value, how much of filtrate is being formed, what do you think is the normal urine output? 0.5 to 2 liters maximum. If you're passing 3, 4, 6, that means there's something wrong. Okay? So 1.5, let's keep it as 1.5 to 2 liters per day. This is your urine output. This is your urine output. Anything more than 2 or 2.5 liters per day urine output will be classified as diuresis, increased urine volume. Increased urine volume. Okay, so 1.5 to 2 liters is the maximum. Now coming to Meredith, even if someone is starving and not taking any water or food, the minimum urine output is 500 per day. Okay, minimum. Because we cannot throw out our waste products as pellets. Okay, there are animals that can do that. They conserve all the water, so the urine comes out as solid. But we cannot do that. We need some water to throw out our waste product. So the minimum urine output, minimum, even if somebody is not taking any water at all, minimum urine output is 500 ml per day. Okay? 500 ml is that little bottle of water that you buy. That is 500 ml. So that's per day. Okay? Now think about this. So your filtration is 180 liters per day, but what you're actually throwing out of your body every day is about 1.5 to 2 liters. So what's happening to that remaining 178 liters?
Reabsorbed.
Reabsorbed. This is where you understand this. 178 liters per day is being reabsorbed. So if you look at these three processes, tubular reabsorption is really important. Because if this doesn't happen, you're going to lose fluid. You're going to lose electrolytes. So tubular reabsorption is very important. So out of that 180 liters that is being filtered out every day, only 1.5 to 2 liters is thrown out as urine. So all of this is getting reabsorbed. So where was I? Yes, if anything becomes less than 100, if the GFR falls less than 100, then it is a cause of concern. Okay? if you are checking the GFR, if you're looking at the kidney functions and you find that the GFR is only 60 ml per minute, this definitely indicates a kidney issue. Okay, so people who are having kidney disorders, you constantly are looking at kidney function. Now let's see how filtration occurs. Okay, how does filtration occur at the glomerular capsule? What is it that pushes? This is exactly like capillary dynamics, exactly like capillaries. Okay, so I'm going to remind you about the capillary and then we will look at this very quickly. I won't go into detail. I'm pretty sure some of you would have forgotten, but let's just put that. So blood enters the capillary from the arteriole. So that's your capillary. And then it leaves and goes into the venule. This is your normal capillary in the rest of the body. Enters through the arteriole, this is the capillary, and then leaves through the venule. So when blood enters, the pressure with which blood is entering the capillary is roughly 35 millimeters of mercury, okay, which pushes the water and the nutrients out. And then as blood flows through the capillary and goes towards the venule, the pressure drops to about 15 millimeters of mercury. And your osmotic pressure, the osmotic pressure is around 25 millimeters of mercury all the time. So this is what pulls the water back in along with the waste products as blood flows to the capillary. So you call the capillary the exchange vessel. This is in the rest of the capillaries. Now in the glomerulus, this is where the difference is. So the cup is like that. This is the cup. Afferent arteriole brings the blood in. Okay, the afferent arteriole brings the blood in. And then it goes through the glomerulus. I'm just drawing one capillary like that. And then you have the efferent arteriole through which the blood goes out and then it goes into the peritubular capillaries. The efferent arteriole is narrower than the afferent arteriole. So in the kidney, when blood enters the afferent arteriole, the hydrostatic pressure, that is the blood pressure, okay, is not 35 because it is entering into this glomerulus. The blood pressure is 60 millimeters of mercury. Why is it higher than this 35? Because you see this efferent is also an arteriole which is narrow. So it is difficult for the blood to flow out. So the pressure here is always high because the blood has to push through this efferent arteriole. So the hydrostatic pressure in the glomerulus is 60 millimeters of mercury. And it always remains at that 55 to 60 millimeter range because blood is going out through the efferent arteriole. It's not getting into a venule. If it was a venule that was coming out of the glomerulus, then this pressure will not be so high. You cannot maintain it. Remember, arterioles can constrict. So they are able to maintain the pressure. And you need this high pressure in the glomerulus to push the liquid out. And the osmotic pressure, the plasma proteins are not getting filtered out. So the pressure is still 30 for that. Osmotic pressure is 30. But they cannot pull that fluid back in. Osmotic pressure pulls the fluid. But it will not happen because it is much lower than this. So hydrostatic pressure is about 55 to 60 millimeters of mercury. And this is the pressure that pushes the liquid out. Okay? So that's the difference between your regular capillary and the kidney and the glomerulus. So the pressure or force that favors filtration, pressure or force that favors filtration, that allows filtration, is the hydrostatic pressure in the glomerular capillaries, which is about 55 to 60 millimeters of mercury. And it is high because of the efferent arteriole, which is narrow and constricted. So this remains high. Pressures or forces that try to stop filtration. So at the glomerulus, it is like a tug of war between two pressures. One of them is trying to push the liquid out into the cup. It is trying to allow filtration. There are two other pressures which are trying to stop the filtration. One of them is the osmotic pressure. The proteins that are still in the blood, we are trying to attract the water back in. They are trying to pull the liquid back in. So the pressure that is trying to stop filtration is, one of them is plasma colloid osmotic pressure, which is due to the albumin, which is not filtered out. And this is roughly around 30 millimeters of mercury. So as this pressure is trying to push the liquid out with all the dissolved substances, the plasma proteins are trying to pull them back in. But that doesn't happen because this is much weaker. This is a more stronger force. So it pushes the liquid out with the dissolved substances. Another pressure that is of a slightly lesser significance is the cup itself. As the cup starts filling up with liquid, so it's just like your coffee pot. If you put too much of water, the coffee fills up, and if it is more, if you have added too much of water, then it starts spilling over. Here it can't spill over, but it will try to stop filtration. Okay? But that again, in a normal nephron, it doesn't happen because this fluid will flow down. It will start flowing down into the PCT. So this pressure of the liquid that collects in the cup, that is called the hydrostatic pressure of the capsular space. Hydrostatic pressure of the capsular space. That is the fluid that collects in the cup. This also tries to stop filtration. Hydrostatic pressure of fluid in the capsular space. That is the Bowman capsule. Okay. This is only about 15 millimeters of mercury. Roughly 15 millimeters. So 30 plus 15 is trying to stop filtration. 55 to 60 is trying to allow filtration. So 30 plus 15 is still less than 55. So 30 plus 15, 45. This is 55. So this is stronger by about 10 millimeters of mercury, by 10 points. So filtration will occur all throughout the glomerulus until the blood leaves through the efferent artery. So this 10 millimeters of mercury is referred to as net filtration pressure. Net filtration pressure. Because that's what allows for the filtration to occur. Now I'm going to ask you a few questions which will help you understand what can happen, okay? How things can change. And think about it carefully before you answer. It's not very difficult. It refers to these pressures. Now let's say if this hydrostatic pressure, that is blood pressure, when it comes into the glomerulus, let's say this pressure increases, okay? Due to some reason, maybe the person has high blood pressure. So this hydrostatic pressure in the glomerular capillaries, instead of being 55, let's say it increases to 65, okay? 10 points higher. None of this changes. None of this changes. What will happen to filtration? Will it increase or decrease or stay the same? It will increase. Exactly, right? So when you 65 minus 45. So you see the net filtration pressure has doubled. So filtration will increase. So the person is going to have the glomerular filtration rate is going to be higher. Okay? So you understand how these pressures can affect filtration. So that's one. Now, let's think of something, another one. This is 55, it remains the same. The osmotic pressure, normally it is 30. Let's say it drops to 20 instead of 30 because the person has some hypoproteinemia. They don't have enough proteins in their plasma. Instead of 30, it drops to 20. And everything else remains the same. Okay? Now what will happen to filtration? It will increase. Why? Because this is actually a pressure that stops filtration. So if this is going to become 20, 20 plus 15 is only 35. And then this is still 55. So again, the net filtration pressure is going to go up by 10 points. So filtration will increase. Okay? So just so that you understand, when you see certain diseases, you might see that the GFR is high. So at that time you should be, although you may not be actually measuring any of these pressures, it should bring to your mind that, oh, if I see somebody who has low protein levels in plasma, there is a high chance that the kidney is filtering a lot more than what it should be filtering. Okay? So filtration will increase. When hydrostatic pressure in the glomerular capillaries increases, or when plasma colloid osmotic pressure decreases. Okay, which is what you just saw in the examples. Now, a third one. Okay, think about this. So let's take this nephron. You have the PCT and the loop and everything, okay, like that. DCT. Let's say there is a stone, urinary stone blocking the distal convoluted tubule of this nephron. So the fluid is not able to flow past that. It's not able to flow. Now what will happen to filtration in this nephron?
Decrease.
Filtration will decrease. Why? Which pressure is going to go up?
All hydrostat, the capsular.
The capsular space. Because once you block the flow of the liquid, everything is going to collect in the cup slowly. Okay, there'll be a back pressure. Fluid will not be able to flow. So the pressure in the cup is going to go up. And at one, if this keeps on going up, if this 15 keeps on going up, it is going to stop filtration at some point. And once filtration stops, this nephron is non-functional. It's not going to function.
Until the stone will pass.
Until the stone passes or if it is removed. Okay? So that whether if the stone is in this nephron, I'm just giving you this example, but let's say it's in the ureter. Okay? It will cause a lot of pain. Of course it won't, but it can have effect on the kidney because the urine is not flowing, so everything is dammed up. Like everything is bad. There's a back pressure. Okay? And it can cause damage to the nephrons. So that is, you know, although this is very theoretical, nobody measures pressures. We don't measure these pressures in a patient. We don't do that. What we do look at is the glomerular filtration rate. We look at, creatinine levels in blood, we look at urea levels in blood to see whether the kidney is actually throwing out all this or not. So if the kidney is not functioning, definitely you will see all the waste products in blood, the level will start increasing. Urea levels will increase. Creatinine levels will increase because the kidney is the one which throws it out. So a kidney function test will include all of this. Apart from the GFR which is calculated, it will also include blood creatinine levels, urea levels. Okay? So when you look at some of those tests, you should be able to make that connection as to why it is increasing. Okay? So this is about glomerular filtration rate, okay, and the normal. So this, for you to understand, what is it that you need to remember? What is the pressure that favors filtration? That's just this one, hydrostatic pressure in the glomerular capillaries. What are the pressures that try to stop filtration? Which is the osmotic pressure and the hydrostatic pressure of the fluid that collects in the cup. Which one is stronger always? This is the one that is stronger. So filtration occurs throughout. Okay? Only in certain situations you can have a difference. So an increase in the hydrostatic pressure will increase filtration. A decrease in the osmotic pressure will increase filtration. And a stone blocking the tube will decrease filtration. Okay, those are some examples that you need to know. So this is again not so, it's not an easy thing to grasp, but if you go through, if you read it, you should be able to figure out. So now, how does the kidney ensure that the GFR remains constant? Okay, because your blood pressure keeps changing during the day. If you exercise, your blood pressure may go up. Okay, but how is it that the kidney ensures that the GFR doesn't keep changing and fluctuating along with your blood pressure? That is, that is an intrinsic property in the kidney itself. The kidney, each nephron is able to control its glomerular filtration rate. Okay, so as long as the mean arterial pressure behind me. Okay. As long as the mean arterial pressure is anywhere between 80 to 180 millimeters of mercury, you know that the mean arterial pressure is roughly 100. But even if it fluctuates between 80 and 180, the nephron is able to maintain the glomerular filtration rate. The filtration rate will not change. Okay, it will still remain the same. Only when the mean arterial pressure becomes less than 80, glomerular filtration will drop. If it becomes more than 180, glomerular filtration will increase. So this is what is homeostasis in the kidney. How does it ensure that the glomerular filtration remains constant even when the blood pressure changes? Okay, so this is what is called autoregulation. And if you look at your textbook, it gives you two theories to explain autoregulation, but we are not going to go there. Okay, those are theories. More if you're actually going to, going to a PA school and all that, you will have to study about autoregulation. Okay, but at this level, you don't need to know that. Just remember that each nephron has the capability of adjusting the glomerular filtration rate even when the blood pressure changes. And that is what is called renal autoregulation. Okay? And then, of course, extrinsic control. If, the blood pressure drops, then you have all of these renin-angiotensin-aldosterone mechanism, which will try to keep the blood pressure up so that glomerular filtration does not change. Okay? So we will go through that. Then we have looked at renin-angiotensin, but we will take a look at it again. Okay, so now let's go to the second part. Okay, and this last slide is whatever I just mentioned to you. Okay, the one that I just mentioned to you. Plasma protein, obstruction to the flow of urine. Okay. So let's look at the tubular reabsorption. Okay, and then we'll stop for today. I have some questions for you, so let's see if you can. Okay, I'm not sure whether you'll be able to answer all of them, but. Tubular reabsorption. So the second mechanism which happens in the renal tubule, okay, reabsorption recovers the useful materials from the filtrate. So how is reabsorption going to take place? You will have, so filtration has occurred, and as the fluid filtrate moves through the tube, substances are taken back into the peritubular capillary, which comes from the efferent artery. They're taken back. So there are three ways in which they can move. One, they can go from the lumen, from the tube, through the cells, the cuboidal epithelium that lines the tube, go through that. This is the interstitial space where there is some connective tissue and a little bit of fluid, and then it gets into the blood. So you have this form of transport. Or it can go through the gap junctions between the cells. So the ways of transport, passive transport, active transport, all of that can happen. So it can either go through the cells that line the tube and get into the blood. This is called transcellular transport. That means it is going through the cells. Then you also have transport. It can come into the cell and then go through the junctions between the cells. Okay? Or it can go through the junction between the cells. That is called paracellular route, paracellular transport. So where does maximum tubular reabsorption take place? It occurs in the PCT, proximal convoluted tubule. And the cells that line the tube are cuboidal cells. This is simple cuboidal epithelium, and the epithelium is thrown into a lot of folds to allow for increased surface area. Okay, wherever you have folds, increased surface area. So all the substances are getting transported from the filtrate that is flowing through the cells, through the interstitial space, into the blood, into the capillary. Okay, this is how it is getting transported. So we are going to look at what are the substances and how they are transported. Okay. So this slide is important. Okay, this is a kind of a summarized slide about tubular reabsorption. Okay. So I don't think this is a picture from your textbook. Okay, so you won't see it. But it shows you most of the substances that are reabsorbed. An important slide, so make sure you understand this. So, as the fluid flows through the proximal convoluted tubule, now we are going to look at some percentages of reabsorption. So, filtrate has water, nutrients, waste products. So water, roughly about 70 to 80% of the water, okay? I say 60 there, but even it can go up to 80. 70 to 80% of water gets reabsorbed in the proximal convoluted tubule. Okay, that means there is still 20% of water left when the filtrate enters the nephron loop. So 70 to 80% reabsorbed. Okay. There is something that is reabsorbed, sodium, potassium. Sodium, potassium. also similar. About 70 to 80% of salt is reabsorbed as the fluid flows through the proximal convoluted tubule. Okay. There is something that is getting 100% reabsorbed, and that is organic substances, glucose, amino acids. Okay. Vitamins. These are 100% reabsorbed. That means when the filtrate passes from the proximal convoluted to the loop, there will be no glucose in it because all of it gets reabsorbed. Okay, 100% gets reabsorbed. Yes. Fat soluble substances do get, fatty acids will get reabsorbed. Okay. Most often, again, here you can also add fatty acids, 100%. So you can see that majority of the organic substances do get reabsorbed completely. The process of reabsorption, the transport process. Sodium is reabsorbed by active transport because you have the sodium potassium pump. So it's going to pull the sodium into the capillaries. Along with sodium, these organic molecules will hitch a ride. Okay? So this is called secondary active transport or active transport along with sodium. So sodium, you're anyway using ATP to pull it. So this is like hitching a ride with it, like carpooling that you do. It's the same thing. So other molecules carpool with it and they get reabsorbed. So sodium is active, primary active transport. Glucose, amino acids, vitamins are active transport along with sodium. So if sodium is not there, they cannot be reabsorbed. So you need sodium. Anything that is fat soluble can go through the cell membrane very easily. Urea is fat soluble. Fatty acids, passive diffusion. Negatively charged substances, chloride, follows positively charged substances. So chloride is by passive transport, electrochemical attraction. So once sodium gets reabsorbed, this positive charge will attract the negative charges. So this is passive electrochemical attraction. Water, of course. Water, you know, the only transport mechanism for water is osmosis. So when all of these molecules are getting reabsorbed, water will follow. So water is by osmosis. Now the percentages here that I told you, 70 to 80% of water, 70 to 80% of sodium, okay? 100% of all of these. This is important. So what happens in the proximal convoluted tubule? The reabsorption percentages are more or less fixed percentages. These are fixed. What I mean by fixed is that even if the body requires more water, the proximal convoluted tubule will not increase the reabsorption of water. It will still be 70 to 80% of water from the filtrate. If the body requires more salt, let's say somebody is on a low salt diet, so the body needs to conserve all the salt. It will not happen in the PCT. The PCT will still reabsorb just 70 to 80% of the salt from the filtrate. Okay? So what happens, the reabsorption that happens in the proximal convoluted tubule is more or less a fixed thing. Okay? So now comes the question of where can the reabsorption change if the body needs more water, if the body needs more salt? Where is it going to get reabsorbed from? So that is going to happen in the distal nephron. Distal nephron.
That includes the DCT.
DCT and collecting duct. When you say distal nephron, it includes the DCT and collecting duct. And this is where it is in the DCT and the collecting duct that fine tuning of the filtrate takes place. Fine tuning of the filtrate takes place based on the needs of the body. Okay, based on the needs of. Is it getting recorded, Esmeralda? You think it's right? Because I didn't put it on. It's on the table. I forgot completely.
It's still recording.
It's still recording the voice? Okay. I forgot about it. Now it's only 5 minutes more. So forget about it. Let it be there. So some of these words that I use for explanation, you may not find it in the book. So sometimes it's easier to connect when you listen. So only in the proximal convoluted tubule will do everything according to what it knows to do. Everything is fixed. Okay, it will not be able to change just because the body needs more water or more salt. It cannot change it. But in the distal nephron, which is when the filtrate goes through the distal convoluted tubule and the collecting duct, that is where fine tuning of the filtrate takes place based on body needs, based on the body requirements. So if the body needs more water can be reabsorbed. If the body needs more salt can be reabsorbed. If it doesn't need more salt can be thrown out. So this is where fine tuning occurs. And why does it happen only in the DCT and the collecting duct? That is because most of the hormones act on this part of the kidney. Hormones bring about the fine tuning. So they are the ones that are going to fine tune the filtrate based on the body's needs. And majority of the hormones act in this part of the nephron. So ADH, aldosterone, all of them act here. Parathyroid hormone, they all act in the distal nephron. Okay. So calcium gets reabsorbed in the proximal convoluted tubule, but only a fixed percentage. Anything extra, if the body requires more calcium, it will happen only in the distal nephron under the action of the hormones. The hormones will be able to control how much of reabsorption takes place. Okay, so that is about the proximal convoluted tubule. So I want you to have this nicely, understand this well, because this is the main region where maximum tubular reabsorption occurs. So you should know the mechanism. So sodium is active transport. This is secondary active transport with sodium, passive diffusion, electrochemical attraction, osmosis. And remember, in no region of the nephron, water is reabsorbed by active transport. Water is always osmosis. Okay? It cannot be active. So it's always osmosis. And this is important. We will look at most of the hormones you already know. We will look at this fine tuning, which happens in the distal nephron. Okay? So kidney is, again, not an easy topic, but we have really, this part can be, if you look at your textbook itself, might have a lot of details. Lots of details. But at this stage, I think at least if you understand this, you know that proximal convoluted tubule is where most of the reabsorption occurs. And very important, glucose, amino acids, vitamins are all completely reabsorbed. We'll talk about why glucose is seen in a person who is diabetic. Okay, 100% of glucose is absorbed. So if you take a sample of your urine, you should not find glucose in it. If you're otherwise healthy and have no other issues, you should not find glucose in it. Okay, so there is a difference now. So why do you not find blood and proteins in urine, normal urine? Because they don't get filtered at all. Blood cells don't get filtered, proteins don't get filtered. Why does normal urine not have glucose in it? The reason is different. Normal urine does not have glucose because all the filtered glucose is reabsorbed in the proximal convoluted tubule. So the reason is different for these two. Okay? So proteins and blood, they don't get filtered. That's why you don't see it in urine. Glucose gets filtered because it's a small molecule, but it completely gets reabsorbed. So in a normal person, you should not find glucose in urine. So next class, we will see why you see glucose in a urine of a diabetic. Okay? And why when you take vitamin supplements, okay, when you take vitamin supplements, you can see sometimes your urine smells of those vitamins. You can see the color change in the urine. Some of those water-soluble vitamins will get thrown out of the body. We'll see why. Okay, why that happens. And people who take protein shakes for bodybuilding. So if they take a lot of protein shakes, you will find amino acids in urine. So under normal circumstances, you should not. But people who are on a high protein diet, they're taking protein shakes and protein drinks, you will find amino acids in urine. Okay, we'll talk about that, why or what is the reason for seeing it. Okay, so let's stop here. So what